Dr. Sanjay Chaudhary. Invite Dr. Sanjay Chaudhary. You have already spoken, no?
No,
Oh,
no.
there was a
Chitra,
confusion here.
you worked so hard in this conference. It's
No,
showing.
no, no. We had gone to the next sessions actually mentally, judges and all that, who has come and all. So he's going to talk on bandage, contact lens, scaffold for the management of PCR with residual nucleus. And we have Dr. Mayuri Kamar. I'm so glad that the election is over. With this slip of mine, some of you wouldn't vote for me.
Okay, thank you so much. So I'm talking about a contact lens scaffold in a PCR with residual nucleus.
Dusra paper.
As you see this video, you have to keep three things in mind. Sorry. As you see this video, so sorry. As you see this video, you have to keep three things in mind. So far, the technology promoted was an IOL scaffold for PCR with residual nucleus. We were doing IOL scaffolds, but the three problems we found in that technique. One, the lens was thicker in the center, so the AC was shallow, and when you were doing the nucleus pieces removal, you were very close to the endothelium, so there was endothelial cell loss. Two, the IOL once inside the eye had to be positioned into the bag or the sulcus. That means your access to the epinuclear material and the cortex was limited, and many a times you had to leave that matter behind because you couldn't pick up the whole thing outside. Right? So we devised a system where you could first have a scaffold, take it out, and then remove the epinucleus and the cortex. So with these things in mind, just watch the video. Can you start it from the beginning, please? I haven't started it yet. Okay, so you see these large nuclear pieces. The PCR is already there. The vitreous is already there. I'm cutting the vitreous strands so there is no traction. The best way is you pick up each strand with your left hand, and for that you need three hands actually. One hand is being covered by the ACM. So your two hands are free and you can comfortably go around tracking each vitreous strand and cutting it. Now this is the contact lens scaffold. The size is 9.5 millimeters. We worked through several models, 10 millimeters, 9.5, 9, and we decided that 9 is the best comfortable size. 10 becomes too big, 9 becomes a little smaller, and there's a risk that it will not hold on the iris and fall into the vitreous. So you need a support. Now you just inject it with any IOL injector and open it up, concave surface up, and direct these nuclear pieces on the concavity of the contact lens. Why a bandage contact lens? Because it is thicker. The central area is 100 microns. Normal contact lenses are thinner. They could collapse and fall into the vitreous. So you needed a thicker contact lens. So the nuclear pieces are guided over this contact lens. It is opened out on the iris. You bring the nuclear pieces in and at ease emulsify them without fear that these pieces will fall in the vitreous cavity. So emulsified. Now the main job done. Now I'm trying to bring out these thick epinuclear pieces because this was a hard cataract. I could do that afterwards, but I'm doing it before also. So I'm bringing out the whole epinuclear girdle from the under the contact lens to the side over the contact lens, something you cannot do in an IOL scaffold. Bring it up, comfortably emulsify it. Second hurdle gone. Now there's all that PCR and the cortex, and I don't need an obstruction like an ICL in the system, so I just hold it and pick it out. It's just so simple. Now this whole area is open before me. I use a vitrector for irrigation, aspiration, and cutting. So in the IA mode, I hold the cortex, bring it to the center. In foot paddle 3, I activate the vitrector, and that cuts the cortex along with any attached vitreous strands. So I'm removing the attached vitreous along with the cortex, and everything is coming out so smoothly. There is no falling of these cortical matters in the vitreous cavity. There are no strands which are vitreous strands which are coming in my way and causing a tug, and have a total, complete, smooth cleanup. Everything looks as if it was so simple. And now is my time to go in with an IOL. I'm doing a sulcus fixated. In it goes. And because it is sulcus fixated, I do an optic capture. So this is the optic capture. Thank you so much.
Thank you. Thank you very much. We
Uh,
go on to Dr. Mayur.
Congratulations for the nice video and the good concept.
Thank you, ma'am.
But I'm little uncertain whether you can hold the contact lens can hold the high pressure of the and vacuum that you are
Yes,
doing.
ma'am. So we don't work at a bottle height of 110.
So-
We are working at an IOP of 40.
Okay.
So that pressure is not there.
Not there.
So I use the Centurion system with a fixed IOP, or my other colleagues who don't have this system, they have a bottle height, so they work at a bottle height of 70.
In that case, it might dislocate.
Very high pressure, the pressure will be too high, even that can collapse inside.
Yes.
Because what is holding is just the iris, and iris is
Iris.
very flimsy.
Do you constrict the iris or it is just like that?
I do what?
Meiosis? You
No,
induce-
no, because if I do a meiosis, I may not get a dilation later on to remove my cortex.
Okay. It was a nice concept.
Thank you so much.
Any endothelial cell count was
Sorry? The cell-
endothelial cell count.
Yeah. So when I did my IOLs as a scaffold, the cell loss was almost 30-35%. But in this, the cell loss was 15%.
Yeah, I'll also go.
So I saved
Yeah.
20%.
I invite the next speaker. Thank you.